Welcome back to the studio right here at Lagos Talks 91.3 FM. It is past 11 right here in Nigeria, and we're getting into a conversation around global health. So if you're joining them from Canada, which is about 6 o'clock, if I'm right, at this time, or anywhere in America, ranging from 5 to 8 or 9 hours behind. Well, we just want to say good morning to you. If you're joining from Kenya or South Africa, 2 or 1 hour difference, or anywhere from Egypt, China, it is time for us to have a conversation around global health. And you know that I don't do this alone. I do this with a legal mind, someone who has a profound interest in humanity and the health sector. He is a professor. I'm just a broadcaster. So he will be taking the lead in a lot of the conversation we'll be having today. And that is in the person of Professor Ngwaba, joining me again all the way from Toronto this morning. Prof, good morning to you.
Good morning, Kaide.
Great. And how is the weather over there this morning?
It's a bit pleasant today. It was a bit hot a couple of weeks ago, but now we're getting into very cool weather.
Nigerians don't believe it when you say it's hot over there, because like, when we come there, what you call hot is still chill for us. So,
oh no, it gets hot during the summer, trust me.
Okay, all right. Good to know. But today, we're having a conversation around regional health governance, but we are looking at the unsettled global health territories in the age of Trump, framing a regional health governance agenda for the American system. That is a mouthful.
Yes, it is. And I'll let our guest, when we get to talk about this, to really introduce the idea behind it, because this is a project. This is based off a project that she's working on under my supervision. But then, we're making very interesting findings and discoveries, which we would like to discuss today on the show with our audience. About why there are global health territories that are currently unsettled because of US President Trump's action in global health or against global health, and what that means for the inter-American system, but also significant implications for the African system as well.
All right. So, and of course, those of you who have been a part of this from the onset, you'll understand. And for those who are joining in for the first time, let me introduce to you who my as a panelist or co-presenter this morning is. And now, Professor Uchechukwu Ngwaba is an assistant professor at the Lincoln Alexander School of Law in Toronto Metropolitan University and the managing partner of Massfield Legal Practitioners, a transnational law practice with offices in Lagos, Abuja, South Korea, Busan in South Korea, and Toronto, Canada. His academic journey began in 2010 at the Nigerian Institute of Advanced Legal Studies. He's worked in Australia, and while in Australia, Professor Ngwaba successfully completed a legal qualification degree of the Legal Practitioners Admissions Board of New South Wales, becoming an Australian trained lawyer in the process. His pedagogy is informed by critical decolonial perspectives. He taught as a sessional lecturer in 3 Australian universities for about 5 years. That is the Macquarie University in Sydney, Deakin University in Melbourne, and University of Western Sydney. Now, he's been there, he's done that. He engages critical human rights perspective and post-colonial theory or to examine how health governance and regulatory systems impact health outcomes in the global North and global South. He currently leads a group of research focused on advancing a regional health governance approach in the inter-American and African human rights systems, respectively. Now, today, we're being joined by Aminah Haghighi, who is entering a final year of law school at Toronto Metropolitan University. Yes?
Yep, that's the one.
Yes, she's entering a final year at the law school at the Toronto Metropolitan University and is a legal research opportunity fellow. Her academic and professional work bridges legal research, advocacy, and policy. She has worked on a wide range of issues from algorithmic bias and the ESG to systemic discrimination and regional health governance. She is particularly passionate about the intersection of women's health and the law. Following Dr. Ngwaba's global health course, Aminah was selected to present her research on endometriosis and health equity at a national conference in Nova Scotia. Before law school, she was farming in Prince Edward County, actively advocating for mothers in entrepreneurship during the COVID-19 pandemic. She is a proud mother of two daughters, Rosetta and Isabel. And she's our guest today, joining Professor Uchechukwu Ngwaba this morning. And to you, we say good morning and welcome to Nigeria.
Thank you.
Thank you. This is so exciting.
All right, great. So when you talk of the unsettled global health territories in the age of Trump, now, I think that's on its own an entire case study, the age of Trump. And when you talk about unsettled global health territories, the first thing that comes to the mind of the average Nigerian who understands how health functions is the impact of the discontinuance of funding the US aid. Nigerians are yet to recover from that. So we do understand what you mean. That is what unsettled means for a lot of us here. But let me start with you, Aminah Haghighi. And you have a research project you're currently working on. Let's understand the motivation behind this project and what really you mean by unsettled global health territories and how this affects us, since you're talking about global health territories in the age of Trump. How does it affect us here in Africa? So 3 questions in one. What motivated this? What really is unsettled global health territories, and how does it affect us?
Absolutely. So I'll take a step back here to sort of explain this project at large. And I do want to acknowledge that my bio is a lot shorter than my professors here. So obviously I am not the expert, but I've had the privilege of working with Professor on this project. Um, so this project is really looking at how what you spoke about last week, this global regional health governance idea, this framework, how the global health governance as it exists today has been shaped by unequal power structures that are rooted in colonial history. So it's arguing that Trump's approach to global health, as you just spoke about, the withdrawal from the World Health Organization, defunding USAID, that transactional approach to this pandemic response, the COVID-19 pandemic, that's not what created the instability that we're seeing in the system. This has just exposed what we've sort of already known about what this global health governance looks like right now. So when we talk about unsettled global health territories, it's our way of describing how these institutional, legal, political arrangements are being shaken. They were already fragile, they were already exclusionary, but Trump's actions are just making that more visible. We are super grateful, obviously, to the Lincoln Alexander School of Law at the Toronto Metropolitan University, who's selected and supporting our project here through the legal research grant to ensure we could participate in knowledge mobilization like this on this channel here, present at conferences, and move towards publishing the scholarship, which we're excited about. When we talk about what this project is rooted in, we can look at theoretical frameworks like necropolitics, which is about how power determine who lives, who is valued, which healthcare crises we care about, how they're disposable, that imperial blowback, which shows how colonial practices here in the western side of the world are destabilizing the core health governance of the rest of the world. And these frameworks help us understand that what's happening during the COVID-19 pandemic, like vaccine hoarding, the marginalization of the global south, that was not new. This is just unsettling what had already existed. What I personally think was most inspiring about working on this project, and even just discussing this with Professor, I remember I sent you a text as soon as Trump said, we're going to withdraw from USAID, we're not going to fund this anymore. And you said, that's okay. Like this is exactly what we need. And I didn't really understand what that had meant at that time. But what I think is important here is that it acknowledges that that status quo, how we're working right now, is not working. And so while most people are arguing that this withdrawal is is going to cause a lot of problems, we understand that, but we are also looking at this as an opportunity for something a little bit more positive, what decolonialization by praxis actually looks like, and does it put the power back in the hands on the ground? And I think that that's something that is unique to the conversation that we're adding. And as for your third question here, as for Africa, I think the implications are significant. The same patterns are applying when we look at Mpox, when we look at Ebola, the abandonment of African countries during public health crises, the delay in response, the lack of trust in local systems. All of that reflects the same global health logics that we've already discussed. And so we're hoping that this is opening up opportunities for dialogue between the different regional health governance models that we're looking at.
While it's okay to agree with you by saying that, well, and like what you said, Prof said, that listen, this is what we need. We need to open new frontiers as against relying on, freebies and being funded from territories that do not necessarily understand us. But shouldn't that be done systematically? Because immediately pulling all this out, wouldn't there be a gap in the system as we speak right now?
Absolutely, Kayode. And I think I would like to comment on that. There's nothing very elegant about what President Trump of the United States has done in the context of global health, in terms of defunding USAID, in terms of pulling out from the WHO. There's nothing elegant about that. And we can say that while saying that we have an obligation on our part to make sure that no one wields that kind of power and influence over anyone or over any country or system, regardless of how impoverished it is. Now, the aim of health, achieving the right to health, is really about strengthening the capabilities of societies or individuals to be able to pursue good health. What has happened up to this point is that the abilities of many African states and societies to be able to achieve, the right to health has been severely compromised. Now, the problem is that the compromisation of the structures in this society has not been entirely been done by necessarily bad leadership or necessarily lack of development. It has been done actively with the remote control or the remote influence of the very same societies like America or global North societies that are now trying to withdraw aid or aid funding. Now, let me just share with you an interesting data or statistic. It will shock you to realize that Africa gives more to the global North than the global North gives to Africa in terms of foreign aid. In other words,
Okay, what does
we
that
actually, yeah, I suppose the question you want to ask me is how is that? How is that
Yeah,
possible?
that's why I want to first of all understand what it means by we giving out more when even
Oh,
almost everybody is looking at the North, the global North for support.
oh, it's good you asked. Thank you for asking. Well, our resources on the continent actually powers the development of the rest of the world. Europe is not going to be where it is today without the resources from the African continent. I don't need to tell you about what is going on in the Congo. I don't need to tell you what is going on in many other African countries. The extractive industry in Africa is booming, and that boom is being driven not by Africans or African technologies, it's being driven by Western technology that are here mining and exploiting and stealing and pillaging. Many of you are familiar with obviously the story from Burkina Faso about how their resources were underpriced by the French until they drove them out. And suddenly overnight, they began to, record very impressive numbers in terms of revenue inflow. The point I'm trying to make, Kayode, is that the exploitation of the African continent did not begin today. It began from the period of slave trade. After slave trade, during slave trade, of course, our human resources was exploited to develop the industries in Europe and America. After slave trade, we had a period of colonization where it was economic exploitation of the workforce and the talent base and even resources from the continent to develop Europe and America. Now, let me tell you why colonization happened. Colonization happened because of bread. And you're going to ask me again, what do I mean by that?
Is it bread of life you're talking about, or which
No,
bread?
I'm not talking about bread of life. I'm talking about the bread you know.
All right, okay.
When colonization happened in the impoverished streets of London, the government was reckoning with this inability to feed its population. And they said, look, the only way we can feed our population, make sure they have bread, we need to go and, scavenge for resources from territories and subordinate territories around the world. We need to go out on expeditions to, plow new fields of new areas of conquest. And that was what inspired, the active outward movements of, industrial interests like Royal Niger Company that came to Nigeria and colonized Nigeria. East Indian Company that went to India to colonize India. Those expeditions were driven by the search for bread. It's as simple as that. So, in other words, there was nothing benign about that. It was never really in the interest of these colonized peoples. And then after colonization, you have post-colonization, a period of post-colonization. Some aspects of that has been done, with a bit of diplomacy and polish, like the way the British have done it. They indirect through, and then they gave us our independence, but we were never really truly independent, but we pretended as if we were. But then you had the French who could not be bothered to pretend about it and who continue to, and up till today, have their former colonial territories under their clutches, running their financial system, running every aspect of their economy. What am I trying to say? What I'm trying to say if Africa was this place that could be dispensed with and wasn't this important part of the world, why the continued and sustained interest on the continent? Why the attempt to undermine leadership? The stories of coups on the continent will not be complete if you don't tell about the unseen hands of Western powers who were sponsoring and motivating these coups. Even today in Nigeria, we struggle with insecurity, Boko Haram. And then sometimes you hear some careless statements being made. Not necessarily careless. There are actually a lot of sense in it where we say, oh, there are Western NGOs that are funding this, or there are Western forces that are funding this. And when you look at the quality of the arms and ammunition that find their way to the hands of these terrorists, it makes you question, really, where are they getting these arms from? We know that these things are not cheap, because go and try and buy these things, you'll see how difficult it is. So my point is that, there is need to realize the political and the socio-political contexts, the power, the politics of power and the dynamics of power that are at play, in our economies, which also have direct implications on our health systems. Because when Nigeria can no longer sustain universal health coverage, back in the day, hospitals were publicly funded, and you didn't have to pay a dime to get services in the public hospital. And then the World Bank and the IMF tells you, oh no, that's not a good economic model. You need to change that model because that's the way to go. All right. So they force us to adopt policies, economic policies, to change those models that will allow us to support our population health. Yet in their countries, they are adopting those very same models they're asking us to change. Look, so I can go on and on to tell you the politics of power, the international politics of power that are at play in the deliberate subversion of our abilities on the African continent to support our citizens, to support our health systems. But what is clear, and what we should just hold at the back of our mind at the moment, is that these things I am describing are the territories in global health that are being unsettled.
Okay, but there are questions I have regarding this, but there's something you said about universal health coverage, and you spoke about the fact that we in Africa advise not to do this, whereas that same model is what is being practiced abroad. So I want to find out from you. Recently, of course, you're aware of the passage of the former president of Nigeria, Muhammadu Buhari, who died at the London clinic in London. United Kingdom. Now, talking about universal health coverage, can a government in Nigeria, or let's use Nigeria as a case study now, can the Nigerian government achieve universal health coverage through public-private partnership, or does the entire funding, have to come from the federal or state government? I ask this to tie it into where our president passed in the UK. It should not have happened. The president of a nation should not die in another country, except maybe you were there on official assignment and something happened. But to the extent that you're sick and you're taken abroad, that hospital, according to what we hear, is a privately run hospital, not government owned. So can we achieve that quality of health care through more of private investments as against government's funding?
Absolutely. You've asked a very important question here. First of all, we need to understand what universal health coverage really means. Universal health coverage is really about access to health services to the people who need them at the price that they can afford to pay.
Exactly.
You know? And of course, I say this recognizing that in Nigeria, the issue of access to health is a major issue for the average Nigerian. The average Nigerian cannot afford to get sick, because if you get sick, that is capable of impoverishing you. That is against the principle of universal health coverage, which says that out-of-pocket health payment should not be more than 40% of your income. And if it is above 40% of your income, that is what the WHO calls catastrophic health spending. So the aim of universal health coverage is really about health financing. It's about insurance, making sure that we have proper funding pool put in place to be able to support, public health. In Canada, if I get sick and I go to the hospital, I can walk out of the hospital without paying a dime. If I run all kinds of tests, maybe the only thing I'll be asked to buy is maybe they give me prescription drugs, and I go to a pharmacy to pick up the prescription drugs, and maybe the drugs are worth about $200, but I end up paying about $20 because the public health system has subsidized it substantially. But then there's still a possibility for me to walk out of that pharmacy without paying a dime, because when I show them my public health card and they give me the public health subsidy, I bring up my private health insurance card, and then it wipes out the rest, and I walk out of that place without paying a dime. So you see how the combination of both public and private funding it comes in very handy at this point to be able to assist for me to be able to have access. Now, why is this important? Because look, health is a very basic need. It's a basic human right. If you don't have the right to health, you do not have any other human right. The right of movement, the right of association, it cannot be exercised if you cannot exercise your right to health. Now, let's bring this back to Nigeria. What does this mean for Nigeria? I would say that what this means is that there is a responsibility that arises on the part of those in leadership to ensure that the basic infrastructure, the basic facilities and conditions, both in terms of financing and regulation, and both in terms of investment for healthcare, needs to be in place to ensure that the average Nigerian, it doesn't even have to be the president or the former president, because if we talk about the president or former president, there are certain, perks of office that these guys are entitled to, which the average Nigerian is not entitled to. I'm saying that the average Nigerian who has the same kind of sickness that the former president had that killed him should have access to health facilities or treatment of the quality and standard that took him to the UK in Nigeria. And so the fact that has not happened, the fact that we are in a position where a former president, no doubt the immediate past president of the country, is having to travel abroad for medical treatment. And did you observe that he was not the only one there? There was also former President Abdulsalami Abubakar.
Oh, yes.
Who said, my brother was also, I was admitted at the same time. I recovered, he didn't recover. I was looking at that, and it was telling me, this is the shame of a nation. Because imagine being in a private clinic where your former president, and you can be sure that there are other prominent Nigerians who did not feature on the camera who were also in that hospital. So is it the fact that we don't have the resources to establish hospitals of that standard and quality in Nigeria, or is it the fact that we do not have the doctors with the quality, with
the expertise,
with the capacity and expertise to be able to offer that kind of treatment?
Is it possible that they've all gone to Canada?
No, no, that's not true. Yeah, I mean,
Oh.
quite a number have migrated to Canada and to other countries in the global north, but then that is not true. Nigeria produces one of the best medical personnel in the world. Like, the Nigerian health educational system, at least the medical education in Nigeria, is still highly respected. Nigerian doctors are breaking grounds and leading big establishments in North America, in the United States, in Canada, and in Australia, and many other parts of the world, and even in the UK. In fact, there's this running joke in Canada that the best place to get a heart attack is in a taxi because your taxi driver is most likely a medical doctor. That's a huge, that's a running joke here in Canada, and it's true. It's true because you come here, you see people will come here with their medical education, and the system picks and chooses who's going to be allowed to practice.
Mm,
Just they don't even find it easy to come here, and yet countries like Canada and the United States have deliberately used immigration as a strategy to attract the best talents at every point in time. Because when you talk about universal health coverage, you're also talking about the health workforce to
mhm,
sustain the health system.
mhm,
Now, Western countries, because they know that they are destination countries, everybody wants to go and live in the West. They are very deliberate and intentional in the way they use their immigration policy to attract doctors, to attract nurses, to attract lab scientists, and all of that. Whenever Canada needs nurses, it makes it very attractive for nurses from the Philippines to come. When it
mm,
needs doctors, it targets doctors from Nigeria and other African countries. These are the things, these are the issues, all right? And so there's both a combination of, political forces, geopolitical and global politics that are deliberately impoverishing African countries and making it very difficult for professionals to live and work in the country. And then there is also the complicity of our own leaders who fail to invest in the health system, you know, to make sure that we build the capacity and capability to be able to provide the best quality universal health coverage.
mm.
Now, let me just, end this point on this note. Did you know that, only a couple of decades ago, the royal family from Saudi Arabia used to come to Nigeria to receive health
Yeah.
treatment? Because
UI,
it
UCH.
was a destination for royal family. Did you know that the health system of the UAE, Saudi Arabia, was actively established or contribute the major contributors to the flourishing of that system were also Nigerian doctors. I have a cousin who's an optician I don't know which Middle Eastern country, but he is practicing as an optician there. That's one health expert who could be in Nigeria, but who is
Yeah.
working there. It's not like I have issues with that because I mean I can't complain. I can't be throwing stones because I live in a glass house myself. So, but it's just I mean it's easier to find a professor, obviously, but then when we're talking about medical professionals who are trained for a very long period of time, that's a different kind of conversation altogether.
All right, and let's go back to the topic, which is unsettled global health territories in the age of Trump. And I'd like to speak to Aminah Haghighi on this. The actions by President Donald Trump, were they unexpected, seeing all the previous steps he had taken regarding relationships and with the global South? And could we as Africans, I mean, who are the most hit, could we have prepared better for it?
I think that I'm probably better positioned to answer the first part, and then maybe I'll defer to Professor on the second part and how you could be better positioned. But I think if we look, for example, at other things that previous administrations have done, when we look at Zika in Latin America, what we are told here in the global north is, oh, don't travel there. As long as you don't travel there, if you want to have a child, then you'll be fine. And we have never really been in a position where we're actually helping people. So I think the actual defunding of USAID, of the World Health Organization, choosing that were certainly things that he had said in his platform, but weren't really moves that the rest of the world thought would actually happen. And I think the pandemic appointing of RFK Jr. certain decisions that he had made in his administration made it so that he would make these things happen. And people in the global north were just not willing to act fast enough on behalf of other people. So I think his message has always been, let's prioritize America. Let's prioritize what we're doing here. Why are we sending this money away? When in reality, it was just another form of that colonization that we were talking about before, this behavior that we've seen time and time again, which is just again rooted in that necropolitics, that imperialism of let's continue to do what we're doing.
Mm.
And let me add to that. The second bit of that question is, could we in Nigeria have done any better? Could we
Yeah,
have done differently?
preparing for it.
Absolutely. We should have been able to anticipate that. We should have also never allowed things to get to the point where, entire services in our public health system are entirely dependent on foreign aid. It will shock you, and I'm sure you know, based on obviously the anxieties and the blowback from the withdrawal of the USAID funding, that there were entire maternal programs, maternal care
Oh,
programs,
yes.
especially in the northern part of the country. But what am I even talking about? Even in the western side part of the
Yeah.
country, that were entirely dependent on USAID.
Oh, yes. AIDS funding.
HIV/AIDS medication
Yes.
was entirely dependent on USAID. I personally have friends, former classmates, who where their work was entirely paid for by USAID. And when USAID withdrew funding, they lost their jobs because no funds to back it up. That is not ideal. Like, as wonderful as it is to get foreign aid, the whole idea of aid is to help you to stand on your feet so that you can develop your own capacity. But then when USAID has been funding you for over a decade, 2 decades, 3 decades, that's a problem. We should start asking questions. When do you grow? It's like that neighbor who you help for that urgent 2K, but he's never able to do anything beyond depending on your urgent 2K. Imagine now that neighbor is living his entire life month on month, and it's that urgent 2K you're collecting. I mean, this is the local joke you won't get, but
Yes.
they gets it. But that's what USAID funding is like. It is the urgent 2K that Nigerians have always been, like Nigeria and other African countries who have been depending on it have been collecting. But then
It's become a lifestyle. That
has
is
become a
who we are.
lifestyle.
Yeah.
It's become a lifestyle. And yes, Trump should not have gone about it. There's no finesse in the way he went about it. But there are certain logics in what he said about the corruption that even the USAID system itself was encouraging. But then, I really don't have any sympathies for the global north about this, because I say that, look, they're simply paying what they owe us. In my earlier remarks, I've said that Africa gives more to the global north than the global north gives to the African continent. In a future episode, we're going to talk about artificial intelligence and global health and health on the continent, And one of the things you're going to be hearing us say is how there is a new frontier of colonialism that is taking place on the African continent, and that is data colonialism. Because artificial intelligence, the raw material for artificial intelligence is data. Okay, our health data, our personal data, our information. Many global north, technology companies are interested in mining that data to train their AI systems. In other words, like colonialism, the more you think we finally close this frontier, a new frontier opens up. And so what that means is that the African continent needs to tell itself some hard truths. We cannot depend on foreign aid. We can't depend on the benign generosity of Western countries, because Western countries are not generous. I can tell you here hard truths. There's no generosity behind it. Anything they give you, trust me, they're going to get back 10 times that in profit.
And that is why. Okay, land on that. Go ahead.
Yeah, I look at, so I'm just going to end with the example of Ukraine and the arms that the US were giving it. And now Trump came around and said, well, you got to give us access to your minerals. And now they've been forced to sign a mineral deal where the US is going to be mining their resources. You would have been thinking, oh, they need weapons to Ukraine to help them to overcome this crisis. But there's no generosity there that doesn't come with some strings attached.
There's no free lunch, like you say.
No free lunch in Liberia, in Freetown.
In Freetown, yeah, that's it. But when you look at this, you spoke about the fact that the West does not give anything for free. And that on its own is one question that we really need to delve into. Why do I say this? When for so long, the West has been giving this aid, and I've had cause to question the motives at some point. I told the colleague, I said, listen, why do we keep getting malaria support, funding to fight malaria, when we know what the source of malaria is? I'm talking to people in the medical field, so I need to be careful to say the source. Before you tell me, well, that's not the actual source, but we know, right? We know. We often trace it to mosquitoes, Anopheles, and all that. Why are we not getting funding to ensure that we build gutters that will be covered? Why are we not getting funding for advocacy to ensure that we have cleaner environments? Why do we ignore funding for all these other projects, but consistently fund malaria, in quotes, prevention or treatment? But if we could say they're getting some things out of it, if that is the case, how come Trump, who is the leader or the president of a leading country in the global north, why has he then decided to discontinue funding or to defund, like it is said? Does that mean they found another avenue to take from us without going through this, spending so much on Africans? Or is it just an error?
In fact, Kayode, before I dive into that, and maybe at some point I will invite Aminah to also jump in. Before I dive into I got to say that you have gradually become a public health and global health expert yourself, because the question you've asked hits at a very core proposition of global health, which is about public health action, which is about the true way to achieving true genuine health benefits for populations is by focusing on underlying determinants of health. So the question you were asking about why they're not funding the construction of proper drainage system, why they're not funding infrastructure, basic infrastructure, these questions hit at the heart of this idea of investing in underlying determinants of health. Now, the short answer to your question is to say, well, they're not doing so because it's not very cool. It's not attractive to invest in underlying determinants of health. It's not easy to capture that in a quarterly report or some end of year reports, because those kinds of investment take time, they take energy, they take resources, and then you don't see it in some visible kind of chart or graph. You just see that there's a kind of subtle improvement in the abilities of, in the quality of life of the people. And quality of life is not something you can really measure in a way that these donor agencies want to measure things. They like to track things, they like to show data. They say we invested so millions, and within so period of time we had a turnaround. So anything that gives a quick fix, that's what they like to invest their resources into. And there's a bit which I also thought was implicated by your question, even though that was not the tangent you were looking at, but I think it is still implicated by it, which is the fact that I thought you were going to ask, why are they funding, why are they giving us aid? Why are they not funding our capacity to produce, responses? Like, for example, instead of giving me foreign aid to buy malaria drugs, why are you not teaching me how to make the malaria drugs?
Oh, yes.
Why are you not building in local capacity, industrial capacity, so that at some point, Nigerian pharmaceutical industry will be able to say, oh, yeah, we are leading research in, developing malaria treatments, in finding the way to cure and eradicate malaria.
Even if it's tropical research or tropical
Even
solutions.
if it's tropical research, like, okay, why are we having a London School of Tropical Medicine and Hygiene when you can have a Nigerian School of Tropical Medicine? Why? Okay, maybe the University of London wants to invest in that school. Why is the University of London not bringing that department and locating it in the tropics? Why do we have to travel to London to go and get trained about healthcare in Africa? Do you understand? It is that paternalism that coloniality, sustains. That's the reason why. Is the paternalistic, response or treatment of Africans. Did you see I'm sure you saw that the Liberian president visited Donald Trump recently.
Oh, yes, yes.
Where did you learn to speak English? You speak
Mm.
English better than some people on this table. I put my head down with my head and hand in my head. I was so embarrassed. I was like, and the poor Liberian president was saying, "Oh yes sir, I was taught well by my teacher, sir." It was
Mm.
so embarrassing. But there is a power dynamics that play there where there's an expectation that you're not expected to be able to speak good English. Africa is not a place of excellence. And
Yes.
so for Donald Trump, he's shocked that the Liberian educational system can produce somebody who is so well spoken. It is that same attitude that manifests in across so many other dimensions in the interaction between African countries and Western countries. There is never this view that we are sovereign equals, whereas under international law, we're supposed to be sovereign equals. But there's always this sense that, look, we will have to manage you. That's paternalism at play.
Mm.
I mean,
Mm.
I want to probably jump in and say a few things.
I think that's exactly what it is, the paternalism. We have things here like shelters for unhoused people. We have food banks where you're able to access food here if you don't have any food at home. And don't you dare ask for more than what we're providing for you. If we give you a very thin mattress and a room that has a little bit of bugs, you should be grateful because I'm at least giving you that. So I think it stems from this idea of if I'm giving you something, you should be grateful for what I'm giving you, regardless of if it's needed. And I think as long as we continue the way things are going now, if we uphold global health as we know it now, other people will always get to decide for you, for me, what it is that we need. And as long as those people continue to decide, okay, I'm going to give you $100 for this very specific thing and you cannot spend it on anything else, then you're going to keep on getting the malaria drugs that don't cost any
Mm.
money because the patent is run up. But we're not going to give you that money to be able to build a proper gutter so that there aren't an influx of mosquitoes or that sort of thing. I think it goes towards what I want my money to look like when I take a picture of you and take it back home. And then also what the cheapest thing is and what will allow me to keep control. Like, what is it that if I keep giving you malaria drugs, you're going to keep needing them for me. And I'm going to keep needing to fund that for you. I would rather do that and give you the vaccine that costs a cent than give you a little bit more money to actually solve the problem because then you're not going to need me anymore. And if you don't need me, that's when we have a problem because that's when you can actually be on your own. And I'm not ready for that.
Mm.
There's a
And
question, was a bit of the question you asked, which we didn't respond to, which is like, what
yes,
is it about
what's
for
this
Trump?
new game plan? Because
What is this game
if
plan?
we are your what do we call it? We your cash cow. Have you
Mhm.
found another way or another source that
I
for
thought
you
that was
to
an
defund?
excellent question. That was an excellent question because it hits at this idea of, the soft power which USAID was exercising with the funding. And by doing away with it, it has left the United States of America to revert to the use of hard power. In global politics and international law, we talk about soft power and hard power. Now, the soft power is using foreign aid, entertainment, and culture, educational, tourism to shape the minds and norms and values of societies so that, they can, imbibe your own values and norms. Hard power is where you use force. So right now, Donald Trump has taken a preference for tariffs, the use of tariffs, bombing countries that don't fall in line, like Iran was recently bombed, threatening to attack countries, just essentially being the bully, exercising your power in a kind of way that bullies everyone. We in Canada, we have also been subjected to our own form of bullying
Oh
by the
yes.
of annexation.
Mhm.
Donald Trump has threatened to make us the 51st state. He
Yeah.
has threatened to annex Greenland. He has threatened to take over Panama Canal. So you can see that there's a pattern here where U.S. foreign policy has completely abandoned decades of using soft power to shape global affairs to now using hard power, being the bully in the room, to exert America's will and influence over the world. we can have a conversation, entire conversations about whether or not that's a sustainable practice. But to your question, that is the answer to it. The answer is America has, under Donald Trump, has dispensed with the need to exercise soft power. They no longer see the need to massage or to cater to anyone's interest and focus on using hard power.
Mm. Wow. And when you talk about what you went through, we know that the jab and the relationship that existed partly with your president, Trudeau, at some point, the interactions that happened between both parties.
Yeah.
We remember that as well. But anyway, let's come back to the conversation right now because we need to wrap up in a short while. When we look at where we are as a people, last week we spoke about regional health governance framework, and this week we're tying it into the agenda of for the American system, and of course, what it means in this age of Trump. How do these two interlace or at any point? Is there any connection between the discussion from last week and particularly the research that Aminah is currently undertaking?
Yeah, let me speak shortly, and then Amina comes in to speak about the rest. What I will just say very shortly is that everything we've been discussing today, as random as it may seem, Kayode, is actually very much centered on the global health territories that we are trying to talk about. All the questions you've asked us today have actually touched on the global health territories that are implicated in this research project. What we're saying by talking about global health territories in the research or unsettled global health territories, we're saying that there are territorialities or structures of power that define the way global health travels, that define the spaces it travels, so defines the people who are important when it travels to those spaces, and that Trump's agenda has really unsettled all of that, and it opens up opportunity for us to, create our own new territory, and that's where the regional health governance approach comes in. That's the connection between unsettling the territories and creating the opportunities. It's like seeing opportunity in a crisis. Amina can jump in at this point.
Yeah, I agree, and that's like the basis and foundation of what we had discussed in the class that I took with Professor here. It's this idea that what's happening in Africa is not happening in a silo. It's happening in several regions across the world that are not the global north. So all of the global south is at the hands of this man that gets to decide if he's going to give this money, if he's not going to give this money, to what, and what that looks like. And so, creating this new framework of what a regional governance program looks like allows to not replicate, these flawed global models that already exist, but how can regions be relying on each other? How can we not be acting in isolation anymore, but creating these networks of solidarity that aren't dependent on the global north? What does it look like if vaccines are manufactured in other places? Data sharing, procurement, what does that look like? And I think that is where our work sort of tries to put into practice what was discussed in last week's episode of this is what this framework might look like in like the ethereal, and this it's very ideal. What does it actually look like in practice? And so I think it's our work more looks at this is what's actually happening, and it's not by happenstance. And then future work will look at, okay, how does this actually happen?
It might be appropriate for us to draw the curtain on the program right about now. And we just want to thank all our panelists for turning up today. But before we even get into that, Aminah Haghighi, thank you for turning up today. We do appreciate the time you spent with us. I guess it's safe to find out from you, at least now you can talk a bit about Nigeria because this is your first visit to Nigeria, I hope.
I hope I get to actually visit in person one day now that I've been on the radio. Yeah.
Yeah, that's it. So your first visit is actually virtual, but you have your in-person visit sometime soon. Just you're with the right person. I'm sure Doc will bring you to Nigeria. Maybe when we're having a global health conference in Nigeria, then we should be able to bring you down. I'm sure we can work around that with Prof just to address some of this and get people from all over Africa to attend. It's important that we address some of these issues. Thank you so much for your time today.
Thank you very much.
Yeah, and
Thank
Prof,
you so much.
Prof, my co-pilot. As it stands now, I think we should probably just hold on to this regional, governance framework or structure for a few more weeks. Maybe if we speak more about it, Nigerians can understand, and even our policymakers can see the need to address this. And maybe on some occasions too, we look at how we could get to engage or compel, force, whichever adjective we have to use here, or now verb, just to get our scholars, the academia, to release and work with the research findings that they have, because some of them do a lot of research. Some of them, they do this research by themselves through very rough conditions with very limited funding, and these research findings are just kept there in a shelf somewhere in school. And God help you, the roof is leaking due to bad maintenance, it's soiled, and everything is messed up. So these are angles that I think we should look at sometime soon.
I'm glad you mentioned that, Kayode. Matter of fact, the research study that I lead, we are now entering a phase where we'll be looking to partner with institutions and with researchers who are interested in this kind of work. Fortunately, we have the ability to access funding here from Canada to be able to drive this research. So the plan is to decolonize by taking the money back from the global north to come and do work that benefits the global south. So really, this is what this study is about. It's a way to contribute back to the global south by bringing a reverse flow of knowledge and resources to be able to help us to develop our capabilities in the health system. So I'm glad you mentioned this. And I'm hoping that there are scholars, researchers, and policymakers who are listening to this radio show and who will be interested in reaching out, when we get to that point where we want to sort of establish, research centers in Nigeria to say, hey, we can contribute our institutional knowledge and knowledge on the ground to this project to make sure it advances. Because ultimately, the uptake has to be done by the policymakers on the ground, and the scholars on the ground need to drive this agenda.
Thank you so much for your time this morning, Prof. We do appreciate once again the time you spent with us.